On-the-scene coverage of ACC.14 is supported by Janssen Pharmaceuticals Incorporated.
I'm Peter Block for On the Scene here in Washington, D.C. at the ACC annual meetings. And we're reviewing the late-breaking clinical trials, and this is a late-breaking clinical trial that broke about 2 months ago. So I'm here with Deepak Bhatt. Deepak is from the Brigham and Women's in Boston. Deepak, this is an interesting trial, Symplicity. It bombed out. It turns out that renal denervation doesn't seem to work, but obviously you looked at the data. So what have you learned aside from the fact that this is a negative trial?
Sure. So I think we have to acknowledge that the trial was clearly negative. It did not meet its primary or secondary endpoints, and that's just a fact. However, I don't think that means that the field as a whole is dead. It just means that this particular patient population studied with this catheter in the way we use this catheter provided no benefit. That doesn't mean that renal denervation might not work in other disease states like heart failure, nor does it mean that other catheters, or for that matter, even this catheter used differently, might not yet yield clinical benefit.
Deepak, I am struck. I'm having sort of a deja vu all over again from this trial, going back to Courage, when if somebody was really hounded about their medications and made sure that they were taking their medicines, they did great. And that's the same sense I get from this trial. Would you agree?
That's one possible explanation, or at least a partial explanation. That is, in this trial, we had patients taking 5 antihypertensives on average, many at maximally tolerated doses. We're talking about drugs like clonidine. So it's quite conceivable that in a clinical trial for a relatively short period of time, 6 months, we were able to get them to do that. That might be harder to replicate in real life.
I agree. Now, you said that there are possible other kinds of technologies that may work on this. What is your sense going forward? I mean, the data from the surgical sympathectomy trials, not trials, but registries back in the 70s, is so compelling. Tell me what you think is going to happen with all this.
Sure. So the surgical sympathectomy, and that's non-selective sympathectomy, those data, there were large reductions in blood pressure, and we know that at least in some patients it worked because there were also bad side effects, orthostatic hypertension primarily, also some other bad side effects, erectile dysfunction, bowel bladder incontinence. Procedure was abandoned once oral medications for hypertension really came to the forefront. So we know that at that extreme, denervation can work. Now what we did in this trial with this catheter, maybe it was too ginger. Maybe it wasn't enough renal denervation. We showed it was safe, but maybe it wasn't effective because we just didn't do enough of denervation or didn't do it the right way. So we're fortunate in Symplicity Hypertension 3 to have an angiographic core lab analysis of all the procedures. We haven't had time to actually analyze it in detail. We've started picking away at some of the data, and there's some signals. Again, I want to be cautious. Anything I'm saying is hypothesis generating in a negative trial. But we see some signals that maybe some procedural aspects had to do with why the trial wasn't positive.
So a lot more to learn from this trial as you dig further into the data. My guess is we'll be talking to you about future trials as well. Thank you, Deepak.
Thank you.